Most of us have. The tracks also has. Yeah, we are live. I think we are live.
Yeah, live.
Yeah.
Yeah. Good evening, friends, and we are back here again with our talk show, the famous talk show, and by Sahesh Dental Academy. And today we have a power packed session. Going to have power packed session with amazing trio, the team with Dr. Miltias from Greece, and Dr. Isaac Tawil, and and Dr. Scott Ganz. So I'm here with my back here again with my team, and it was awaited long last Sunday. We were unable to come live onto the Facebook because of some technical glitches, but we are back here again with root membrane technique, almost 14 years of experience. And I have few words about Miltiadis before we start. And my team is here with me, Dr. Vaibhav Gupta and Dr. Chakshvesh Agrahari. And let us talk, let me introduce you, Dr. Nistias Miltiadis. He was born in 1975. He graduated from the National and Kapodistrin University of Athens, obtaining his dental degree in 2000. By 2003, he completed his graduate studies in New York University in the implant department, where the last year he became a teaching fellow. Simultaneously, he completed a master program in Department of Biomaterials and Biomimetics. He has lectured internationally in many countries like US, Germany, Korea, Cyprus, Thailand, Iran, and there are so many of them. He has also published internationally. Since 2005, he is the instructor in the Department of Prosthodontics in the University of Athens, but also a research associate in University of Kiel, Germany, where he completed his PhD also. In 2010, Dr. Mitsias was entitled a visiting faculty position in New York University at the Department of Periodontology and Implant Dentistry. And let me tell you, he is the creator of, along with Dr. Isaac Tawil, the creator of Root Membrane Kit from Megagen. And we were expecting Dr. Kwambung Park also to be with us, but somehow we were not able to get him here. And now let me tell you about little bit about Dr. Isaac Tawil. He's DDS, MS, received master's degree in biology from Lang University and his DDS from New York NYU College of Dentistry. And he's a diplomat, International Academy, Dental Implantology. It's a big list. Should I, Dr. Tawil, should I continue
No,
or
please. It's
yeah?
no.
Let me tell you, Dr. Tawil has held many main podium session, hands-on workshop at AAID, AMIB, ICOI, CMIC, SciFac, Aegis, Megagen International Symposiums, Osteodensification World Symposium, Dental XP, IADI. Dr. Tawil has been published in several magazines and journals and enjoys teaching live surgical seminars in Mexico. And let me tell you with our um, very respected Dr. Scott Ganz, I don't have to tell you about him. His name is enough. Is 35 years of digital and imaging technology. We had him here with us a few days back, and I don't have, but this team is there, Dr. Scott Gans and Dr. Isaac Tawil. They have a very wonderful program in Mexico where with Megagen, I believe, they do the live surgeries, and they have incorporated navigation and now into that also. And it's a big team there. So Miltiadis, welcome to this show, and we are really looking forward to your 14 years of experience into this root membrane technique. And let me tell one more thing that I had a chance, because this whole team has come to India recently, and when Miltiadis came with Kwambong Park and the launching for Megagen, I got a chance to share the stage with him, and then that time we became very good friends. And he has some certain amazing cases, and I am one of those first few users who have his kit, the root membrane kit with me, and I believe we are going to learn a lot today. So over to Dr. Miltiadis.
Thank you. Namaste. I'd
Namaste.
like to thank you all for being here, because it's a Sunday evening for us and a Sunday morning for Scott and Isaac. Also to apologize to all the people that last week they were here waiting for to watch us. I'm very grateful to Scott and Isaac, and we all should be, especially to Scott, because Scott is a legend, is a living legend, is a figure for all of us, for the things that he has accomplished, and for his friendship. That for me is the most precious thing, because it's a real friendship every day. I know that sometimes I'm breaking his nerves, but it's okay. Right, Scott? And also to Isaac, that we are special friends and family friends too. I have to say that also I would like to thank you, and the whole India has been treating me very, very well. I have a lot of friends and a lot of respect for this country, and I'm sure that the three of us are looking forward to come again and give courses and lectures. Also, last, I would like to say that you're very correct that the AIE is a truly special academy. I don't think that there's any other academy right now in US, maybe in the world, that somebody can take this type of feedback and knowledge in such a short time, compact time. These courses that Isaac and Scott, or Scott and Isaac, because they're both co-directors in this, are giving are so precious. And I think that there is no price for having a course like this, with the knowledge of both of them, the precision and the values that they teach, because it's not only about dentistry and the implants and the grafting and this and that. It's the values that you get and the experience that they have from all of these years, especially Scott and Isaac, of course, because he's a fantastic educator. Regarding Scott, I have no words to say, because he's world famous in what he's doing and how he has done and whatever he has achieved so far. So I would like to thank you then, because I'm also part of this faculty sometimes, and for me it's a tremendously big honor to teach with them these special moments. Right, Scott and Isaac? Yes?
Well, reluctantly we take you, but we love you very much.
Dr. Scott Ganz, please say something.
Yes, we are very happy to be here this morning with you to participate again, and especially all our friends in India and everyone that's watching. We have actually had international people come down to our training center, and Mitsias was one of them who was able to come down and participate and provide wonderful, not only didactic information, but also over the shoulder and live surgery training. And we hope to continue that, as soon as all of this pandemic is quieted down. We're going to ramp up our programs once again, and we hope to be able to invite many wonderful international colleagues to come down to our facilities and join us.
Thank you. So, Dr. Miltiadis, you can share and start your presentation.
Yeah, just a second. See if we can do this.
Yeah.
Can you see it? Scott, can you see that?
I do not see your screen. I just see your face that's not shaved.
Make him just a minute.
Just a minute.
Can you do that? Make him the co-host.
He is
Make him the
co-host.
co-host. Okay.
We'll fix it. Why?
I think you can share it now. Stop sharing and then go ahead again with the green button there.
There you go.
Yeah, there it is.
All right, so thank you so much again for being here. For me, it's really an honor to be with all of you. And again, I would like to thank Scott and Isaac for sharing this Sunday morning with all of us. It's really, I'm feeling very privileged to have you all here. So root membrane has been around, just to tell you, by the end of 2005. This is the true story about this. And we have been working around in many different aspects. We have originally, as I told you, we started end of 2005. Actually, Konstantin Siorbas, not me, that he's the true inventor of all of this. The story is that I came back from US and I was invited in his clinic. So I saw him drilling inside the teeth. And I was a little bit reluctant in the beginning to follow it to this so radical at that time technical procedure. Anyway, by the end of 2009, I was convinced because I already had seen 3-year results. And then we started collecting the data. As you understand from private practice in not the university environment, it's very difficult to have a general dentist put the things down, collect the data, have proper CBCT data at that time, and which we emphasized a lot because we knew how much the CBCT was important in order to show the real thing. And we published in 2014 our first paper with the first 5-year data. Still in the market, let's say there is no other paper 5 years. We already published 10 years also. But imagine that we published 5 years in 2014 with our retrospective study with Konstantin. And of course, in 2018, we published together with the root membrane group. We published the 10-year data. And of course, there is so far no other paper with 10-year data with more than 250 actually fixtures inside and 182, if I recall well, the number of the patients at that time. Now, in general, you saw also from other lecturers that we live in a minimal invasive era. And this minimal invasive era means that everybody wants to have less surgery, less trauma, less pain, less complication, of course, and to have fewer morbidity cases. But also we have all of us to become more and more efficient for the patients and for ourselves. We need to have simpler procedures, faster procedures. We need to provide better aesthetics, more preservative, and to have also better function in the synergy that we are providing. Now, where root membrane stands? Root membrane stands here because it combines all of this. It is a true minimal invasive procedure. It's the cheapest procedure existing in the market. There is no biomaterial to be used here. And maybe this is also kind of a problem we have sometimes with the companies and with the commercial type of thing. But it is a true technique that has been inside this minimal invasive era. Historically speaking, and Isaac and Scott, I changed this slide because we live in a different era right now from the one that we were living some years back. And now we have more and more groups that they provide good data. It has been like a marathon. honestly. It has been like a marathon for all of us, especially for the very first groups that we tried to give data when nobody was convinced. Now everybody's convinced that this technique is working. So we gave them this is the history in the 2006 that Konstantin, I saw the first root membrane. We have 3 cases actually that they're at the end of 2005. The one is with a Straumann implant and the other is with EBI implants, which I found them, Isaac, and I know that the one case is in Germany right now, and I'm trying to find them out so we can provide this data. In 2010, everybody had enjoyed this first publication by the German group, by Markus Kürzeler, Baumer, Zur, etc. And this was a case report with enamel grafting procedure in beagle dogs. Very, very, very strong paper, brilliant work by the German group. Same group published their vertical fracture in 2013. This is a different way of doing this. And personally, I do not agree in doing this type of procedure. This is a paper that shows you an intentional cut, not accidental. It's an intentional cut in the midline of the root. Nevertheless, it's a very good paper. Same year, we have the proximal socket seal published by Joseph Kahn. You know, Joseph is a fantastic person, a true researcher. I mean, he's a brilliant, brilliant person that he showed us another way, the way of the proximal socket seal. Personally, to give you my feedback, I don't know if Isaac is with me or not in this. In my hands, it doesn't work so well. I don't know if your hands, you're a better surgeon than me, and maybe Scott can say something on this. In my hands, I don't find it easy to make it like this. But Joseph, as far as I know, and I know that the data that he's showing is original and there's no comment on that. In his hands, and his long data now that he has, I think it's 8 years of results that he has right now. In his hands, this technique works very well. I don't know if you have to say something on this, Isaac or Scott.
I would say that I think because of his articles, I think it promoted us to extend our shields further into proximally, because of some of the cases he showed where they were next to other implants, adjacent implants. We really want to maintain that bone. So I think it's a good thing to talk about once we get into a little further into the sessions, but the shape of the shield changing from a smaller piece to more wider or going less into proximal, more into proximal has been varied over the years because of these different articles. So it was a kind of a breakthrough for us to say, well, maybe we should take it even further on cases where there are adjacent implants.
Very true. I don't know, Scott, you have to say something on this, or?
If I must.
I'm always asking you because you are my mentor. So.
I think it very well is related to the actual anatomy of the root itself. So I think that we have to consider how much volume we have with the alveolus, how much volume that the root is going to take up. And so I don't think we can make generalities in many of these cases. And I think other people have also explored different techniques that maintain, especially in the molar areas, etc., different shapes than were originally intended with the original socket shield and the root membrane. So I think that there's a place for all of these techniques as long as we diagnose and treatment plan properly.
Exactly, and you see now how the experience stops. It's exactly what Scott and Isaac said, that right now there is no competition. It's just a different way of expressing almost the same thing. We do have things in common with all the groups, but we do have differences. We published 5-year data, our group 2014, and then 2015 we published step by step in IJPRD. We clearly, this is the first time that in a written paper, there is a paper that says step by step. At that time, 5.5 years back, we gave our step-by-step. At that point, this was the vision. This was the way we were looking at the things at that time. So we gave the first step-by-step paper at that time. In 2016, we have the formation of PET. As you all know, PET is an umbrella of techniques. Howie and the rest of the, actually Howie and Maurice and Jonathan, that they were inside this paper, they published 2 papers, PET-A and PET-B. And I think this is also another landmark. I tried to include all the landmarks here in this historical line. We do have the German group comes back and gives us the first volumetric study. This is very important because now you see that we are getting the proofs of the whole idea and the whole concept. We are getting that this thing is stable, volumetrically speaking, and it's not something like we see only, like in a PA or in a CBCT. And again, in 2017, our group gives the first human histology. Now, this is the landmark because this is the first time that we have a human histology, a successful human histology. So far, we have no other human histology of a successful specimen. And this showed us that the whole thing is working. In 2018, again, we gave first the 10-year data. So right now, we do have 10-year data. And you will see that I'm sure that the other groups, slowly, they will get up to there. And we will have more and more and more groups with retrospective and prospective also studies that are coming now. Howie published in 2019 the prosthetic management. I'm glad he published this thing. We were talking about this actually when the kit came first, and we were showing that we are trying to bevel this. You remember this? I showed you this in India and in Las Vegas too. And I'm glad that Howie published this in more detail. We agree in this. In 2019, again, Chuck Streamer, fantastic guy, great person, and I'm very happy for him because his effort and his strive for many years finally came up to the surface with the PET Spot Molars paper in 2019. And then finally, in 2020, we have our 3D study. And if you compare the 2 groups, the German group and the root membrane group, you will see that the results are so equivalent, the 0.3 to 0.2. So this is very important, extremely important, because we do have now comparable data, scientifically comparable data. It's not like I talk or I say this and that, and it works in my hands and in this other hand it doesn't work. No, now we have scientifically data. This is the map. This, for me, it's a map, and I'm sure that I wish I had more space, but I'm sure that other articles are coming that might be even more important than this. But so far, our marathon of all the groups, PET group, root membrane group, the German group, we gave to the Dental Society the data. And this is, for me, the roadmap. Now, where root membrane stands here, root membrane is actually just an equation of immediate placement and root submergence. Here you can see also some literature. We have incorporated Lazara, that first talking about immediate placement, and of course the 2007 root submergence paper by the Salama group. Now, a lot of people are asking many different names for the same thing, right, Sandeep? So I'm sure that a lot of people have asked you already, what's going on? What is this guy talking about? Why he says this, why he says that, why, So I tried to give you the answer. Of course, it's because the whole thing is very important. It is a game changer, okay? And that's why we have so many different names from different perspectives. So for me, just to enlighten the people, for me, my own view, the classification of partial extraction therapy techniques, of all of what we have seen so far, and this is something new, Scott and Isaac, for me, this should be classified accordingly to the PDL-mediated implant placement techniques. This is something that George Kotsakis also emphasized a lot of we're talking about it. And in this, we should include the root membrane and socket shield. The one uses a graft, the other doesn't use a graft. This is a huge difference between the two techniques, and also in the way that we are doing the technique. There are a lot of small differences. And on the other hand, we do have the PDL mediated pontic type of techniques. And here we have the root submergence, of course, we have the Glocker technique and the pontic shield. So this includes everything. Because Sandeep, I saw some other people talking about this in your previous weeks, and somebody was missing the one, somebody was missing the other. So for me, this is the picture. This is the PET, the umbrella that contains everything, with or without. I don't know what's your opinion about this, Scott or Isaac, if you want to comment on this, but for me, it's very clear now that whatever technique we have, this should be the classification.
Yeah.
Isaac?
Dr. Isaac.
I would agree with that. I think that this is the ideal way. And I think the way that you're using this, where it's involved from the periodontal ligament, I think that's the key. And I think that was the most important part of the entire process of this, is that it is a PDL mediated for it, and that it's controlling that, because that should be the focus on what we've been doing for the last a bunch of years. The last, at least for me, almost 8 years of this is maintaining that PDL. So I think this classification that you've shown is actually ideal, and I think it's a kind of a fair way to bring everything together, where it's not termed in any other different manners that get confusing. So it makes a solid representation of what we're trying to accomplish.
Miltiadis, I would like to ask, as somebody who is new to these techniques, and many people are thinking of adopting it, and many people are trying to do that, and many people are doing it, and especially in India, Dr. Udat Khair is, and Ali Tunkiwala has come up with a book also. This root membrane and socket shield, there is a great confusion. Is it the same thing, or there is some kind of difference? Because as per your classification, it is PDL mediated implant placement technique, and it's root membrane or socket shield, or there is little difference?
Oh, there are a lot of differences.
Yeah,
there are a lot of differences. The biggest difference is that we are not grafting, because the way we are performing the whole thing is that we are following the canal, and we are trying to place the implant close to the root. Okay. Our ideal placement is like 1 to 1.5 millimeters close to the root. Okay. If you see what, let's say in quotes, the latest version of socket shield, because if you see what the German group has developed, and this is a confusion, because the socket shield originally is with grafting with endogain. Now, as the years were passing, the other papers that the German group published was without grafting material. And also they were going for screw retained and cemented. In the case that they published in the paper with the 10 in the 3D paper, they had 6, I think, screw and 4 cemented. This shows you that clearly there has never been a discussion about how socket seal should be done. On the other hand, we were very clear from the beginning, and that's why we published also the step-by-step. For us, it was okay to go with cemented, and it was okay to go with screw retained, according to the placement. Now, lately, if you see, and this is the input of the PET group, the PET group has changed clearly the path of the implant placement. They are pushing the implant to a more palatal position from what we are saying. And the gap between the root and the implant surface enlarges, becomes more than 2 millimeters. And this is the key feature. If the gap is more than 2 millimeters, of course you need to put something inside. Yeah. But this is not what we are doing.
Okay.
Another difference.
Go ahead, Ms.
Yes.
Cad. Go ahead, finish your thought, and then I'll make a comment.
Also, other differences we have is about the length of the root, and also of how high the root should be. Clearly, the PET group says it should be at the crestal level. Socket seal originally is, I think, 0.5 to 1, and we are saying that ideally should be 0.5 millimeter above the crest of the bone in order to save some fibers. As I told you, the length also of the root is different of how we are describing how the other groups are thinking, which is fine. You know, we cannot always be the same or have the same perspective. I don't know, Scott, if you want to say something.
Yeah, so I was going to ask you actually, in your suggested classification here, where you have root membrane and then underneath it socket shield, do you want to specify then root membrane and in parentheses graftless and socket shield grafted to differentiate that? Is that how important that differentiation is?
Yes, you're so right. I mean, I was thinking of saying, you know, non-grafting socket sealed sometimes, or, you know, grafting root membrane, you know, something like this. But I think that you're very, very, very correct.
Well, you know, part of the issue that we, if we go back to some of the early publications that relate to implant to tooth position, if you look at all of the literature that existed before CT and before cone beam CT, everybody was talking about placing an implant 1.5 to 2 millimeters from the adjacent, from the tooth next to it. And what they did not understand, based on their two-dimensional periapical x-rays, was that they were only measuring that distance from the crest, and that none of those articles considered the periodontal ligament space, the PDL. And so once we had cone beam CT, once we had CT and we could look at the three-dimensional picture, we could actually define the distance from the potential implant placement to placing it next to a tooth. This is not socket shield, this is not extraction, this is just adjacent to a root. And so I think it's really important that we understand that the periodontal ligament, of course, goes down the entire length of all of the natural tooth roots. And when we're placing an implant next to a tooth, we have to consider that relationship. Now, when we're talking about keeping the root in the alveolus, now we have a better understanding of the lamina dura and the PDL as being really in the essential reason why these fibers stay. And so, you know, this definition of PDL mediated, I think, is really, really important for the understanding of the relationship and the difference between an implant in a bone and a tooth root in the bone, and now the difference between root membrane and socket shield in terms of whether you're placing material in there or not. So when we look at in 3 dimensions and we look at that distance, you know, and when we have 1.5 millimeters from the implant to the residual root that you're leaving, what particle size are you really going to use to graft into that space? It's just not necessary, as you've seen in your histology. And so we know that you're going to get healing without a grafted solution. But you're absolutely correct. Once that gap starts to grow, you could either way. I mean, it's you know, and we've seen cases where you have larger gaps and nothing was placed, and you still get, you know, bone growing into that space. And so there's you know, as you like to say, it's a race, since you've been running so much lately, between the soft tissue and the hard tissue, and so I think that's part of that equation that you have to address when we're dealing with a gap distance that's greater than 1.5 millimeters. So I really like the PDL mediated concept, but I think you need to define it, you know, in terms of that non-grafted and grafted solution.
If I could just add one more thing, I think having the name, you know, partial extraction therapy to encompass all these different techniques makes it an easier ideology so that we know what the treatment is. And then we break it down based off of the different techniques. So we have to give a lot of credit for that, because without having that terminology, I don't think that this technique would be as widely used as it is at this moment. I think you're seeing clinicians all over the world embracing this technique. And it's because of this term, bringing all these kind of names together into one place is easy for us. And then we just have to delve in a little bit deeper to understand the differences within those techniques.
Very true. Very true. I fully agree with you. So root membrane and all of the PET techniques, they change today's dentistry. How? Because 3 words: predictability, reproducibility, and of course, the stability of the tissues. So we just published in 2020, in March, April, this last issue is very, very fresh, came out, the longitudinal, listen to the title, is the longitudinal soft tissue changes during periodontal ligament PDL mediated implant placement. This for us, it took many, many years. I don't know why. We had to convince them. And actually, Isaac, I was looking at the data. It's published right now, and it's with all data. Can you believe that? These are data that we collected from 2011 to 2015, and they published now. Now we are collecting data for the same paper, and they're going to be 9 years. So this shows also the problems with the publication and the need that we have to have faster also data. The 3D volumetric analysis, and we talked about with Scott a lot. This slide shows you the way we did that. We took the cast, and we took impressions. We used the software to scan them, and then we measured in the middle and in the mesially and distal in 3 different positions. And we used chromatography. You see here the different colors in the green, the blue, the orange, and the red. That shows you clearly that sometimes we can have even negative. We can have plus and we can have a negative also in this transitional zone that has been described by many, many, many people. And it's the most difficult area right now that we have to face. Here, if you see our results, and on the right side, you can see the 2D subtractive assessment, the one CPCT over the other after 3, 4, 5 years, depending on the case. And you can see also the non-inferiority testing, the non-inferiority margin at the 0 level. You will see that we have results of an average of 0.2. Actually, it was 0.19. The German group here had 0.3 millimeters. Now, what's the difference between the medial placement? The predictability. There's nobody I know in this world that every time can have a beautiful result like this. Or, we have seen tremendously good surgeons doing fantastic surgeries, but, personally, myself, I don't know, Isaac is a much better surgeon than me, much more experience in GPR. I don't know if you can have always a very nice result, or what you have predictably, let's say, chosen to have. I don't know, can you always have a beautiful result like this? I mean, 10 out of 10, Isaac?
Not with the traditional techniques. If we have,
Exactly.
it's just impossible to get it unless you're, Howie Gluckman, then maybe it works out that way. But most of us have to suffer through a lot of failures and degrees of difficulties on recession or bone level.
I don't know how we can do it, but I mean, and I'm really would like to believe for him, because he's a superior, let's say, surgeon, fantastic, very, very, very talented and skillful, and I wish he can do this. But for me and for the most of the people that I know, having a great result always is unpredictable. Yeah. And the other thing is that even if you have the immediate placement, the standard procedures and grafting, if you have a good result, then for how long is this going? So this is, after 3, 4, 5 years. Sandeep, I'm sure that you have done a lot of cases, more than 10 years of implants, and I'm saying that if you're looking at your cases, after, let's say, 10 years, they don't look the same, right? Even the best ones.
Yeah, I mean, like whatever the results I have been seeing around into to the root membrane technique or socket shield, the best part which I liked about it is that even if the biotype and phenotype there is a discrepancy, by saving the tooth, but you don't have to do anything and you retain the structure and you maintain the soft tissue. That is the most important thing, which I really appreciate that thing. But the problem is that the biggest confusion which the new young people are having, that what to use and how to use to cut the root so that there
We'll
is,
go to this.
yeah.
So we're getting for root membrane is 50%, let's say, is roots emergence concept. Here we see it has been utilized more than 40 years. This is the picture from Salama's paper in 2007 that everybody has read. And from this one, we are getting the hard and soft tissue, three-dimensional stability, because from this we get the PDL. We preserve the PDL, and this slide shows you the mechanism. And this is something that everybody should understand, that this remaining root, by any type of remaining way, provides you with the PDL. The PDL is the bridge for everything. And this PDL keeps you the buccal plate and the bundle bone. Okay, yeah. Not only the buccal plate, but the bundle bone. And then if you have this, you have the facial soft tissue aesthetics. As I told you, we published in 2014 and 15 in IJPRD, and we gave the indications and contraindications. So this one is something that all the people should read. Where to do it: in teeth with poor prognosis, big carious lesion, horizontal fractured teeth up to bone level, chronic inflammatory teeth, not acute. I do not advise, especially to start with vertically fractured teeth. Do not do anything if you see that the tooth or the root is moving. Of course, don't do it in periodontically compromised teeth and no teeth with acute inflammation. I had the honor to publish also in Dentistry Today with Scott and Isaac about the triangle of the famous triangle of bone that Scott has described many, many times. And we saw really that the triangle of bone and the root membrane, they fit each other with very high precision. I don't know, Scott, would you like to say something about this really nice publication we have?
Well, I think it's, again, once we had an understanding of the three-dimensional picture of the root within the alveolus, we had a much better understanding of the different trajectories from the bone and the trajectory of the bone to the root. And so in order to be able to plan these cases properly, it's really, I think, and I think we all agree that it's essential that we have the ability to look at that cross-sectional image as well as all of the other images, of course, so that we can plan the placement of the implant and understand the length of the root and the position of that root in the alveolus. And that was described very nicely by Joseph Kahn in his articles relating to that root position within the alveolus and the maxilla. And so once we have that understanding, back in the early 1990s, when I came out with the triangle of bone concept, it was really to identify the volume of bone that was existing based upon 3D imaging technologies. So the concept of the triangle of bone allowed us to position the implant so it would be surrounded by the most volume of bone. And that usually would mean that we would position the implant towards the palatal aspect in the maxilla, as we've illustrated in this article. And so that position, which was also confirmed by the Joseph Kahn article in terms of the root position within the alveolus, it made the most sense to place the implant towards a palatal position. But now we have somewhat of a dilemma, because if we do that, then we would almost always end up with a cement retained type restoration. And so today, when we're thinking more, going back again to history, we're now going from screw retained to cementable, now back to screw retained, we have to evaluate that position of the implant for either a cement retained with a, let's say, a CAD/CAM abutment, or a screw retained, which would come out more to the palatal and lingual. And so therefore, as the architects and the engineers, the triangular bone concept really lays the foundation for planning that relationship between the bone, the trajectory of the root, and then obviously the position of the implant. So it fits perfectly within a partial extraction therapy root membrane concept.
So surgical protocol, thank you, Scott, was really, really enlightening. Now, the surgical protocol, everybody asks, how does it work? Let me tell you, this should be always a flapless technique, period. Everyone should be looking for a flapless technique, okay? Because you improvise the blood supply. Now, if you cannot do it, or you have a problem, or for any reason, you might burn the case, yes, you should open a flap. Some people are doing a small pouch, and they're trying to see where the root is. This is fine, but for me, having a flap with root membrane or socket seal, I think that you're damaging the soft tissue, and I'm always preferring to go for a flapless way. Then we're having the atraumatic extraction, partial extraction, let's say, and then you have the PDL mediated implant placement. This is the general scheme, okay? Now, this we described it also in step by step. But let me tell you, the whole game, and here I place this question mark, is how to get out the posterior part, the palatal part, or the lingual part. So this is the big question mark, and this is all the technique. Here you can see all the steps. These are beautiful pictures by my friend from Italy, Alberto Prispero, and that we're happy that we have in this multi-center study that starts right now, and this is very fresh news. Here you can see the whole process of going from the root and giving you these wonderful results and the wonderful type of tissue that we all are enjoying after we are having successful result. Now, look at this. This is the beauty of this type of techniques. And we are seeing this every time we're having this technique, either with socket seal or with root membrane, the one way or with the other. Look at this beautiful way that we have the emergence profile. There is no other technique that can give you this beauty, because simply, Sandeep, this is the beauty of nature. And nobody can compete with the beauty of nature. If you see with GBR, we're seeing overgrafting, pouches here and there, connective tissue on top like this. Sometimes they look like excessive overbuilding tissues. Look at this. This is harmony of tissue. Only these partial extraction therapy type of techniques can achieve, and especially in a long-term way. So in details, we are trying to go from this route to this type of scheme, preserving and having the soft tissue either at the bone level, at the root, or half a millimeter, and then place the implant inside, have no contact of the threads of the implant with the root. And of course, in order to achieve this, we need to have a good engagement inside the alveolus. I think that at least 3 millimeters is sufficient in order to have a proper initial stability, because it is important to have an implant, very important to have an implant with at least 60, let's say, ISQ values of initial stability, because it is very important after to give a provisional. It's very important to give a fixed provisional, or to be able to give a custom type of provisional, or either we use it with the VPI, this beautiful technique by John Vergoulis and George Papps, because you are enhancing the emergence profile. Now, do we have any concerns? Like with every type of technique, we have concerns. A lot of people are asking, what about the existing endodontic materials, like gutta-percha? We have a lot of teeth that we're doing it, okay? So it's very clear, and I think that we all agree, we should remove all the endodontic remnants. We should clean the root. We are not going to place an implant inside a dirty environment. And I think that everybody is accepting this type of concept. On the other hand, by creating a good emergence profile, we are not allowing the bacteria to go inside. And also, what about the exposure also of the root? We have seen in many publications, and in generally, I'll show you also that we have this internal exposure of the root. Now, long-term data, 13 years ago, this is Dimitri. It's a famous case that I'm showing all over. I'm always thirsty to show this because it's a fantastic case that Konstantin did. Here, if you see, there is a lesion also here that we placed. At that time, this is end of 2006, so it's more than 13 years. We're trying to find him out now again to have new pictures, but because of coronavirus, we couldn't, there was the lockdown, so we could not move around. So at that time, and it's very interesting to see, if you see in the middle picture, you will see how close to the root that implant has been placed. So really, there is no place there for grafting. Here you can see the CBCT, and if you really see on the left side where the implant is placed in comparison with the distance of the root, there's really no space there to place something there. And at that time, we were leaving the root much higher than what we are doing now. Here's a chairside provisional, fixed provisional, and an abutment that we placed at that time. And this is a PFM restoration that we placed at the end of 2006. Now we followed the case in 2007, 2008, 2013, and you can see also that this periapical type of lesion here that we have throughout the years, it has been filled up with bone. We had a small resorption of the root, if you see the tip of the root, but I think this is because of the environment here that we have this chronic lesion. This is 9 years of the case with a PFM, a simple PFM cemented restoration, and it looks like it's new. For me, it's not the white aesthetics. For me, it is the pink aesthetics. And look at this papilla. I mean, this is so difficult to achieve a so nice pointy triangular papilla. As I told you, we were monitoring our cases. We did again a CPCT. You see that everything is there. The bone is there. This is a PA that we did, and 10.5 years. Look at the emergence profile of this crown. This is unbelievable that we are enjoying right now in dentistry. We have now in our armamentarium the way to provide beautiful aesthetics. Look at the papilla here that we have in the midline. This is so pointy, so triangular, nothing to do with this round type of papilla that we have with the GBR and the increased also type of contact point. Here again, this is 13 years after. So we're really talking about long-term data, okay? 13 years of a case, and it looks like it's new. Now, 14 years of root membrane, 2006 to 2020. Konstantin, as I told you, I developed what he invented, of course, with the help of my friends, Isaac, Scott, some other people. George Kotsakis has always been very close to us from the beginning. We had Michael Picos. We had the honor to have Michael Picos in this publication together with us. David Garber published in the first two publications, and we're still working on some data that we have. And I'm very proud for this team. And I want to tell you that we are always welcoming inside our group everyone that wants to come and join us. In these 14 years, we published in implant dentistry, we included 250 implants out of 182 patients. This is the longest study existing right now in the world. We had a 10-year survival rate of 96.5, and here I have the patient distribution. So you can see how analytically this work has been done with the gender, the age, the smoking habits, and everything. And all the number of the fixtures, where was it in the position, the type, the length of the implants we used, the diameter, and everything. So everybody can read this paper. Here we have also the reasons for tooth failure and replacement. And you can see that 61% was a tooth fracture, a horizontal tooth fracture. We have destructive caries on 36.4%. and we have internal and external root resorption in almost 1%. In total, we have 250, and this shows you here also the cumulative implant survival rate, implant-based 10-year cumulative implant survival rate of 97.3% was found at the implant level. Now, a lot of discussion has been done about the complications, and we will talk about it also with Isaac, and I'm glad that I showed in your previous also webinar that you gave, that there was a discussion about the complications. Because, you know, the years are passing, and we are seeing, we're looking at more and more complications, like in every type of technique. So here we have, again, from this paper, the complications and the failures, the type of complication, root fiber infection, periimplant mucositis, or infection with the fistula. We have different types of combinations, implant mobility in the absence of infection, implant mobility with or without in removing the root, because here is a classification also. Should you remove the implant? Should not remove also the root? Should you remove everything? Now, you asked me about the gap. Here, so you can see, you see the sentinotomy and orthotomy that we were doing at that time. This is actually Constantine doing this surgery, and at that time, we were drilling inside the root with the normal implant drills. Of course, the wear was tremendous, but at that time, this is how we were doing it. There was no kit at that time. There was no paper. Nobody else. This was really practical. This is 2009, and here you can see this is any rich prototype implant that Dr. Park was very gracious to give us to test them. So look at this now. This is how we were doing it. At that time, so the discussion about extending or not, here is what Isaac was talking about. At that time, we were drilling inside the tooth on a 360 degrees. We're increasing the diameter 2, 2.5, 2.8, 3.3, and then we were cutting. Sometimes we were cutting more than 180 degrees. And here is a typical case. This is more than 180 degrees. It's 190 degrees, maybe even more. And then we're drilling inside. Now look at this. This is the big question mark. This is Isaac. This is the first time I'm showing this. Here's the big question: how thick this root should be, and how we're doing this whole thing, even after how we prepare it. And also about the grafting. Look at this. This implant that is placed here is 3.5 millimeters. There's no doubt about this. So if this diameter of the implant is 3.5 millimeters, the gap between the implant platform and the root is less than a millimeter. It's so obvious, right?
Yeah.
So what can I put there?
So it's funny.
Really,
if I can
nothing
interject.
to place there.
So if I can interject, there's only one material that I think you can get in there and to fill into that space. So, and that would be like the NovaBone material would be the only thing that you can kind of squeeze in.
Yes.
However, I think what you'll show, and I think what you've done over your career in terms of doing, because you're a surgeon, but you're also a prosthetics master, I would say. Some of the work that you've done, which I've seen, I have patients that come from Greece with temporary cement and things like that. You asked me to re-cement temporarily because you're watching these cases or building on the cases. Your work has been outstanding, I have to say. Even people I know that head to Greece to come to your clinic to get affordable, magnificent cosmetic dental work. So that's been your forte for many, many years. But I think part of that is the immediate temporization, as you're about to show, can be just as effective as the gap, as filling that gap. Instead of filling that gap, the main purpose of filling the gap is to prevent that soft tissue migration, as Dr. Ganz was alluding to earlier, as to what can fit into that space, and that's been the major factor, creating that barrier of defense. So if whether you're doing that with a graft material or you're doing it with a specialized healing abutment, like the VPI system or a not anatomically designed healing abutment and blocking it out with something. That is the main goal, to try to prevent too much tissue migration. And as you know from your own histology, which I'm sure you'll show, a little bit of tissue migration is definitely not detrimental to this procedure. In fact, in some cases, you may even want to encourage a little bit of tissue migration.
Exactly.
The,
And
the
something
only,
that we say here, because this is very important, and this is another point that, and I'm happy that Howie said this also in another webinar. Here, it's absolutely important to use, because you have a root there. The root covers 40% of the socket, okay? So definitely the tip that I should say, and I absolutely agree with Howie, and I'm sure that Isaac and Scott also will say this, that you should use only a titanium cylinder as a provisional. Nothing should be on it like acrylic, prefabricated or whatever. You use your as thin as possible. And also another tip that we, the dentist, the restorative dentist, the prosto, whatever, we should say to our lab technician, in these cases, do not use masks. You can go all with stone model, or if they want to use masks, let's say the silicone mask, the technician, for any reason, they should not take any scalpel and remove any type of gingiva from the cast, because this can be deleterious for the case. Because if they give you after a bigger type of abutment than the space that you have there, it's suicidal. Then the only thing you will do, because probably if you're inexperienced, you will try to screw this inside and then you will push the root. And if you push the root with this even less than a millimeter of bone, then you will lose the whole case. So it's very important to realize, it's tremendous, the importance to realize the lack of space, of prosthetic space that we have there. And this is why it's important to bevel this type of root. And that's why also Howie's paper is important, because it gives you also the details of how to do it. I will show you again after what we're showing from 2017, but I think that we have an agreement on this, right, Scott and Isaac?
yeah, I'd like to make one other comment on that, on the image that has the measurements. So what you're seeing there, first of all, is going to also be implant specific. When you have a platform switch design versus a non-platform switch design, that may have an effect on the distance between the body of the implant and the outer and the inner aspect of the root membrane. But when you're looking at that 1 millimeter measurement there, it's very important for us to understand, again, when we're dealing with this image, which is an occlusal shot, we're only looking at a horizontal measurement from the implant to the root membrane. If we looked at the actual cross-sectional image on a 3D cone beam CT, you would see that the horizontal measurement, in other words, how deep does that actual space go? Sometimes it's really not, it's not necessarily all that deep in terms of again, the space. So that space, when we're looking there as 1 millimeter, it may not exactly be 1 millimeter the entire length of that root. And therefore, precision in placement becomes very important. And an understanding of that anatomy becomes very important, because not all roots are going to be perfectly straight, and that distance can vary. And so again, it just shows the importance of understanding those measurements. That's just that's one measurement at that occlusal spot, and you need to be able to assess it, like you can see in this image very clearly with that cross-sectional image. Now you see that the apex of the root, which is the other comment that I wanted to make, the apex of the implant, I'm sorry, we need to be able to make sure that that implant is going to be stable in the bone. And therefore, you want to extend your preparation of the osteotomy beyond the apex of the natural root so that you can engage host bone. And that position that you're showing right there is absolutely a perfect triangular bone position. Excellent cone beam CT there.
Yeah, there is a question, Miltiadis. Many people who are into the GBR techniques, they always have a question that what is going to be there in that thin space? Because one side it is the dentinal shield, and other side it is the titanium. And whether it is 1.5 or 2 millimeter or 0.5 millimeter or a millimeter, what is going to be formed there, even if we place any graft material or not? That's a big.
Isaac, would you like to give this type of information?
Yeah.
Well, I think you can show the histology slide first. I think that might give you the best. Are you going to be showing that very shortly?
Yes.
We can come
So
back.
I think
to that.
let's wait.
We can,
Yeah, let's wait for that because
Yeah,
I
sure,
think it's
sure.
important to see it in cross section, and then
Sure,
we can talk about it a little bit more in detail with science behind us instead of just
definitely.
yeah. But
I
that's a
just-
great
So the only
question.
way we
It's a
can,
great question. I
prove
think
it-
that is the ultimate question. That is the question. And then
Yeah.
what? And he'll go through it now. Go through it. Yeah, you're about to do it. Go for it.
Yeah.
So far we have the in PDL implant placement, we have the Hirscheller's histology that it's with endogain. So he gave this new cementum type of formation, and these are the slides that he gave at that time from 2010 in the Journal of Clinical Periodontology in Beagle Dogs. Here we have also the proximal socket seal by Joseph Kahn, and I'm looking forward to his long-term results. But the human histology that we published here with Scott shows you that we have bone everywhere around the implant. Now, this implant that is successful, and we were very lucky to have it because of an accident, a car accident. Now, this shows you that us, the Constantine and me, at that time, we made a mistake, because if you see, there is bone everywhere. Okay, so we have bone here, 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 everywhere. The only space that we don't have real bone is here.
Yeah.
Now, why we have this? We have this because we didn't place the implant as deep as we should. So even the experts are doing mistakes. And on the other hand, the root was not prepared as it should. This should be also lower. Maybe it's the cut also of the, I don't know, the lab or whatever. But for us, shows to us that we should do the implant placement even deeper than we were doing at that time. Nevertheless, okay, Sandy, if we go closer, you will see, and look at this beautiful picture. And again, I would like to thank Adriano Piantelli and Francesco Mangano. Adriano had yesterday his birthday, and happy birthday, Grande Maestro. So here it shows to us that the titanium can be microns close to the root. Even though you see here that the bone has found its way to go in between the root and the titanium. This is an unbelievable picture. Even the bone has done a footprint inside a footstep, you know, it's like stepped inside the root. This is a superb picture that the Piatelli and his Giovanna Lecci gave to us to publish. If you ask me about bone to implant contact, we had a 76.2% of bone to implant contact. This is a fantastic number, you know. This is a huge number. Very, very rarely we see this type of picture. Now, let's talk about this picture here, because everybody will ask, what is this? This, we analyzed for days. This is a non-infiltrated connective tissue. Very stable, 5 years after. Here, there is zero inflammatory cell. So we have a very, very stable connective tissue that here blends with the bone. If you see the red on the right side of the picture, it blends so healthy. And this shows to us that this would be pure bone if we had made a different type of implant placement. So I think that it is our mistake, and that's why we have even this healthy type of connective tissue, which for me, it doesn't bother me so much. Now, Isaac, would you like to say something on this?
No, I think you nailed it on that. I think that's ideal, what you said. I think that we showed with the histologies of the difference of
All
that,
right.
and maybe using the MDGAIN is the reason that they formed the new cementum in that study. I think that's the key, and that your histology is very different from that because of the fact that you didn't use any additives inside of it.
Now, in another webinar, Sandy, you asked somebody, and I was very happy to hear, a good trick from Howie that he said that you should suggest your doctors to give this for free to the patient. He's absolutely right. So something that we see all the time, especially to rookies, okay? My suggestion should be to start with a case like this. A case that has an enlarged canal, very easy, because the most difficult thing in this technique is to find the apex of the root. The most difficult thing. So if you have a case like this, that you can really find the apex of the root, measure it and find it, in an easy way, because just taking a rim and go down and remove all the gutta-percha takes you down in an easy way to the apex of the root, gives you a very good primary solution for the rookies, for the people that they start, now they do the first, second case. So they should select a case like this, that is easier for them, and also a case that has a lot of bone to play with. Because if you have the bone, then even if you do a mistake, you can correct it many times. So everyone should start like this, I think. And I think also Howie's tip of giving this case as a free case, it's a good type of example. Now, you do the case, you finish the case with a temporary like this. Now, why I have this here? Because especially again for the rookies, also for us sometimes, for us, we see this many times. You saw this in the internal exposure in other people's papers that we came with complications. This is not a complication for me. Some people are considering this a complication. Personally, I don't consider it a complication because your case continues like this. This is a second stage modification. It's just a simple miscalculation from us that, we should have taken the root more down. It didn't happen. We didn't see it. We didn't do it perfectly. It's okay, things are happening. So you can very easily, and here I have the drill, the round drill from our kit, that you can have it in 3 different legs. And with this, you can very easily modify, take this down, or the final shaper too, take this root down to either to bone level or 0.5 millimeter from the bone level, and then take it down where it should be, and then finish your case with whatever you want. In this case, we use the zirconia button. You see how nicely the zirconia blends with the soft tissue. And because you have the soft tissue here, as you see how pretty it looks and pointy, then a good technician can provide you a very nice IMAX crown. And 3 years later, you can see the case looking like this and be very happy and look like a magician to your patient. Now, scalloping the root. How are we doing the things now? Nowadays, we are trying to scallop the root. And if you see on the left type of the picture, you see the emergence profile. The emergence profile starts from the root. So we're trying to make it like a ruffle type, like a bevel, but gradually going up and also giving the space to the technician, okay, and to biology to create a perfect emergence profile. It's a change that we have seen throughout the years, and slowly we have developed each group by its own way. Now you have it in a written testimony with Howie's paper. we have been doing this for years too, but it's a good thing that all the groups are agreeing to this. Then you can have your proper implant placement. Again, you see how this implant is placed. You don't need to place a graft here because everything is ideal. And then you can go and you do whatever you think is better, a cement case or a type of screw type of restoration. How you do this? You do this by using the kit. There are several kits right now in the market that we have seen. We have the root membrane kit since 2017, the first really complete kit that came out in the market by Megagen. We have PET from Bracler kit that came before us, I have to say. And then now we have a new kit that came with PET kit from Howie. Personally, I think that the kits are very, very close. Little bit small differences the one with the other, and I think it's a kind of a personal taste who prefers to use the one or the other kit. In my kit here we have the step-by-step, and here we can see the analysis of how somebody should do this. You do first the removal of the endodontic materials with any type of burr that works in your hands, and then we have a 7mm high-speed burr that you can go inside. You can take a PA here, check the angulation, and then continue with initial shaper 2. This is a magic drill that takes you down, and you can really measure with different type of arrows here, because as I told you, this is a blind technique. You should go on a flapless way of doing it. The most important is to hit the apex. So with initial shaper 2, you can really go to the apex and then start the mesiodistal cut and remove the palatal part or the lingual part of the root, as the graph shows here. This is the most important part of the technique. If you achieve a perfect cut and you can get rid of the palatal part of the root, then you're halfway down, because then you can prepare the root according to your needs, take it down to the level that you want. You have all the free space to do whatever you want. You want to go for root memory, you want to go for modified socket seal, graft, not graft, doesn't matter. It matters to remove properly the palatal part. Now,
by the way, Isaac might want to chime in terms of some of the new instrumentation that he has helped develop with TBS.
Absolutely.
to remove the atraumatically remove that palatal root in this particular case.
Yes, please.
Isaac, we lose him?
Yeah, he's there. Isaac, can you? Yeah.
Sorry, I was on mute. I didn't realize, and I was yapping away. Yeah, so I think part of what we've tried to do is to create a kit that will assist in all these different kits. And I do want to thank, the Brasler kit was the first kit. Before the Brasler kit, remember what we were doing? We were sitting there and using straight hand pieces and trying to hold them up in an angle, trying to reach the apex. And it just wasn't possible to be able to get there in the posterior region. So that Brasler kit opened up the door for more second premolars and molars to be able to accomplish a lot of this. So I think that was a big innovation. But we at the instrument company that I am a partner in, which is TBS Dental, we created a different types of an elevator. We call it the Icepick Elevator for this, because it's very much shaped like an ice pick, which Mitsias can use to ward off all his enemies in Greece, right? In addition, we've also made very small micro serrated curettes. They're tiny, so they can get very much to the apex and help you to remove the gutta percha material, any cystic tissue or granulation tissue. And lastly, to remove that palatal portion, we are famously known for our Frings spring-loaded forceps. And we've included in that kit, we like to include the Ganz Frings forceps, which was made by Dr. Scott Ganz. It has a very small beak, and it has a spring control, so we can grab it very easily to remove it and extract that portion and not damage the buccal portion that we're leaving in place, because the ultimate part to this is you can have great success if you follow the procedure correctly. But if you start to mobilize that root membrane, that shield, whatever you want to call it, that piece of root that you left behind, if it starts to get mobilized, that's where we can come with issues in terms of failures or in terms of problems with shield migrations and things like that. So it's important for us to keep that solid to be able to accomplish it. So some of the keys are there to help us facilitate and make this easier, including this kit as the others have shown as well.
Yeah, I would like to talk or say something about it in between. Can I, Miltiadis? Can I say
Yeah,
something?
sure.
Yeah. The first time I got this kit, I found that as Isaac is telling about that, it becomes easier for you to, and especially I like the idea of having that bevel drill where you can bevel the membrane. And when I showed that case to someone, he said, you have tried and you have failed. But now when you are showing this a little bit of the membrane poking out, which is beyond the crestal level also, and you said that it's not a failure, it's not the thing. So I believe uh, I was right at that time, but I was not knowing that. So with this kit, I believe you get the best hold of things, and you can be very clear about it. And one more question I would like to ask is, do you introduce the osteodensification also into this? Is it
You will
of
see
any
it
use?
later on. We are big fans of also densification, and you will
Yeah.
see also that Isaac is doing it. We are using it whenever there's a need to, and more and more. This is coming into our everyday life, you know. So I mean, last Friday I did 2 surgeries with this, and I felt so lucky that I have these bears because I feel much more secure in lifting up, you know. Especially in the crestal lift, this is unbelievable. How much more secure we can do this now, and not banging also, you know, the patients. Something I want to say that is very important.
Yeah.
And I understand also the insecurity of a lot of rookies or people that they're doing. Sometimes even us, the experts, let's say in quotes, we are leaving a part of the root or the root tip inside because we made a mistake. We are human beings. We are not machines. So what can you do? And this is my answer, because a lot of people are saying, oh, why you need this kit and why you need that and that. So I will tell you something. How easy is to continue to do this technique if you have left inside this apex inside? There is no burr in the market that can go inside 20-something millimeters and destroy this apex. But if you have this round burr in different diameters, we have in 34 millimeters of length, then you can really go inside, destroy this apex with a round burr easily and continue. So this is another use that we have not thought about it many times. It's priceless, the help that you have with these specially made round burrs in order to continue the case. Now, after you do that, you start to prepare the root from inside out, and then use the final shaper to get it down either to bone level or 0.5 millimeter. Again, with the final shaper one, this is a smooth surface burr because you want to protect the soft tissue. Soft tissue is precious and valuable. And that's why we have this type of burr that cuts only in the inferior surface. And here there is also kind of a guidance to show you the thickness of the root, that it should be 1.5 millimeter optimally. After you finish this, depending on the level of experience you have, you can either use this, again, high-speed burr to go on the palatal direction and place your implant, or you can go directly with your implant type of a burr. We have incorporated inside the 2 and 2.5 millimeter one-piece burr. It's like use the extender, but in a one piece, because sometimes the teeth adjacent, the height is too much. And that's why we think that the 2 and 2.5 It's very important to have them. After that, you can use any type of burr and then drill that you want in order to proceed and finish with your implant placement. But before you do that, you should use this special tapered diamond burr. The tapered diamond burr, we have given this inside the kit because the palatal wall, as you know, is very strong. And because you do have a root there, this presence of the palatal wall sometimes pushes you too much in front. So if you bevel this palatal wall a little bit with this tapered diamond, then you can facilitate a really good implant placement as you see here inside. And then you can continue and you can do whatever you want, a cemented or screwy type of restoration, really doesn't matter. Here it's clearly, and as Scott was saying before, that the implant should be placed longer, higher up than where the root is finishing. Now, the root membrane kit, if you see it here, you can see it also in a 3D animation, and this is very important to see. I'm sure that all the people will enjoy this.
Yeah.
Initial shaper one. I don't know, Isaac, you want to comment on that?
Sure. So I think the initial shaper is perfect for getting us down to that initial 7 millimeters, so we can make our interproximal cuts from edge to edge with ease. And then we would go in with the IS2 shaper, which is a very long burr with very nice markings to take it to depth and finish the horizontal cutting or sectioning, which is different than the method that we originally used by drilling through the root. The round burr then takes it all the way to the apex, and you want to go and clear out the apical portion with it. We then can use the wider round burrs to start to reduce the coronal height of that burr. This burr, we want to leave a little bit of an edge so that we're not cutting and damaging any of the tissue. Preserving that soft tissue is obviously extremely important. So the final shaper burr is used then to take it all the way down to your desired length. And then after that, just something that I really like is doing this internal bevel. I learned this very much, and from the works of the PET group as well, in terms of making this internal bevel so that we have more prosthetic space. And we got to credit the group from the PT group, from Howie and Maurice and all, in there step-by-step with that for bringing the bevel to the attention. And then using just the regular drills to start clearing out an osteotomy, which should be palatal to the site of the osteotomy. We don't want to follow the root's trajectory in most of these cases. It's going to be more palatal because typically, as Dr. Ganz was mentioning, it will end up out through the facial plate if it's not in that triangle bone. So this is where that triangle bone concept comes in immensely.
Yeah, and Isaac, we have to mention that, especially as—
And actually, hang on, I want to just talk about this burr before he skips it. This burr, I actually don't use this burr. Richard Martin actually showed me how to use this burr on the facial aspect, or the internal portion of the facial aspect. I prefer that burr for the internal portion of preparation, that last burr that you saw, instead of the palatal, but I do use it on the palatal or lingual surface if I can't get the implant down to the desired depth, instead of using a wider osteotomy twist drill, which could cause the too much removal and lack of primary stability at the palatal lingual portion there. Sorry, Scott, go ahead.
Oh, no, it's okay. Yeah, because the video is running. But, you know, first of all, this animation is much improved from the earlier animations because it shows a more palatal position of the implant and a deeper position apically, so that you have apical fixation. But as Milton likes to say, for the rookies, but not just for the rookies, for anybody that's doing these cases, you can't forget that the internal part of the socket has cortical bone. So if you're not controlling your access into that angle that you want, that palatal position, that your drill has the potential for bouncing off of that cortical plate and going in the path of least resistance, which of course, as Isaac said, may lead you to pop out through the facial. So it becomes very important that when you're creating your initial point of entry into that palatal part of the root, that you do it very carefully and you continue that way so that you don't migrate towards the buccal.
Yeah, there is one question that if to Dr. Scott Gans, that if a guide is provided with this, like if somebody can make a guide for this, for a newcomer also, I believe it becomes little easier for them to place. What do you have to say on to that?
Yes, both Isaac and myself have come up with different types of designs for doing guided, not just guided approach, but fully guided based upon our textbook on guided surgery applications. So we are actually able to create a guide that will help with the sectioning of the root itself to get to the right depth and to the
Okay.
right angulation, so the trajectory of the root. And then we
Okay.
have a guide that will allow for the proper placement of the drills to create the osteotomy. And that's where these guides become very important, so that you avoid a compromised placement, because all of this should be planned in the interactive treatment planning software, and therefore we can do both static guides that are separate and are stackable, as Isaac may show if we have time, and we can also do this, as Isaac may also show, with dynamic navigation that you mentioned earlier, which is also would be considered full template guidance, because we're creating a virtual template in order to be able to guide that position. So very, very important message, Sandeep, is that yes, we are big advocates of using guides when possible for these cases.
Thank you, because
We will
as
show you later
yeah,
on this.
yeah,
Before we go this, let me
yeah,
finish with this because it's important. So you
sure.
should at least have, if you do a successful placement, at least 1 millimeter of thickness and at least a millimeter of space, let's say, between the implant thread and the root. Also here, we're showing that the implant should be at least a millimeter below the crest of the bone. Now, if you do this, you will have these 4 millimeters that everybody's talking, and then you'll be able to also to give these beautiful papillas, because now you can apply the contact point, the 5 millimeters of Dennis Tarnow famous article. Now, this all works like a hybrid system. This is the unique feature of this, because you have the best aspects from implant, and you have also the best aspect from the typical, dentistry that we can use without implants. And this root is giving you the unique features. Okay, this is a really unique type of combination. Now, a lot of people are asking about extending the posterior areas of and full arch. Here I have the beautiful picture from your own Udata, and I would like to thank him a lot for giving this to me. It's a fantastic case that he incorporated everything inside in this type of placement. Now, Isaac, would you like to talk about this, since these are your slides, or you want to say a comment? The only thing I want to say is that people are asking, why should we do it in posterior areas?
Sure, I'll definitely
And
comment.
the answer,
So I think, oh, go ahead. I'm sorry, go ahead.
the answer for me is not the aesthetics. The answer is because by doing it in posterior areas, we are getting out of the picture one of the biggest problems that implantology has, that it's the food trap. As Isaac, right? Food trap, you're calling it?
Absolutely. I call it the dessert tray. You know, when you finish eating your food and then 1 hour later, you feel that little corner over there and you're just like that. So this is the dessert tray of dentistry. But I'll let you discuss the case because you do know it well. But I do want to give a lot of credit here to Dr. Chuck Schwimmer. He's the first person to have shown me a molar case, and this inspired me to do this case that you'll see in a moment. And he's a bit, I don't want to call him a cowboy because he does things under the right conditions, but he took this to a whole nother level on several different aspects here. as many of our other colleagues, including Ali and Udata, have done really beautifully inside of the Indian group from India. So please, Mitsias, please, you can take them through the slide.
Here you can see the case, and also it's in combination with our kit. And you can see the use of the round burrs here and the final shaper one. After we finish, then we're taking out the lingual part of the roots. It's not just for anteriors, as you're saying. And then we can apply the spot type of drilling or any type of different way that works better as in the surgeon's hand. As Isaac said, and I agree totally with you that Chuck had a lot of criticism and had a lot of difficult time in the past, but I'm so proud of him, and I'm very happy that his results are very promising. And as you said, he took it to a different level. This is very important. This piece of the puzzle is very important for all of us, because now we do have very nice data for posterior teeth. And here you can see also the methodology. And this is what we were talking about, the osso-densification burrs. So this is the use of the osso-densification burrs in posterior, but also in anterior, that we can use them. And of course, the any ridge implant placement, the blue implant that gives us tremendous initial stability, as you see here, in just two sides of stabilization, not 360 degrees, we can get a 72 ISQ values in this immediate placement. And after that, you can use either a big healing abutment like this one, that it's 8 millimeters, or you can use again PRF in combination with the healing abutment, PRF with a custom abutment, or VPI, a nicer profile, or VPI with immediate loading or temporization. A lot of different combinations. I think that all the combinations lead to the same result. It's a matter of quality and time also of healing. This is my opinion. I don't know if Isaac has the same opinion. Here you can see the outline and the shape, and after this, the technology that we have right now with digital type of impressioning can lead you to a very nice result. Here we see the CBCT of the result. And here you see with the dots, this is a, I think you remember when we did this picture together. It's very funny.
In India.
We went
it was
to
actually
airport.
in India. Yeah.
And we were in the airport together with Isaac, and we did this. We were brainstorming, and we were discussing about this photo. And you can see really with the outline of the teeth with green, but with the dotted line, you can really see now that in the tooth that we did the PET, there is keratinized tissue, and there's a good emergence profile. There's no food drop there. But in the adjacent tooth that is an immediate placement without the preservation of the root, look where the line drops down, and be sure that the food is gonna go there. This immediate placement tooth and the food drop, they're best friends. I don't know, Isaac, do you have to say something?
Yes, I think it's important for them to know where this picture was made, and it was made in New Delhi. Actually, we worked on this slide in New Delhi in preparation for a meeting, and I think yes, it's important. This is the dessert tray that we speak about. This is what happens often: long-term complications with bone resorption, and once we extract the tooth and lose that facial plate. So here we are, being able to preserve the PDL, preserve the bone, preserve the keratinized tissue, so that we can have removal of these food traps, especially in the posterior region, which patients are always complaining about. And that's what differentiates an implant from a tooth. And when we work with this technique, when we work with this brilliant ideology of being able to maintain the PDL, the tooth does not become an implant retained tooth. It becomes more like a natural tooth. We treat it just like a natural tooth. And that's the beauty of the entire philosophy of this partial extraction therapy techniques.
So moving on, because somebody asked about the guidance, and here I will give it to mainly to Isaac and Scott. The first time we did this, actually it was Dr. Park that did this. Is 2017. This is a case that he did with 4 root membranes at that time. This is really pioneering. At that time, we you know, this is how he prepares the root also, and we remove the root inside, and then he prepares by using the kit. The kit was just released at that time, and you see how easily the root can be taken out if the preparation is proper. Now, really, this is according to the style. If you use a round burr more or less, if you go with the final shaper, or you use more the final shaper 2, or the round burr, the small one or the big one, and then you use, you know, you see how the roots are down and nicely polished and shaped. After that, with the use of R2 gate, we have prepared the implant placement to these teeth, and you can see how the different drills are being used in these 4 teeth. And after we finished the preparation, then you can really bevel, as Dr. Park is doing the root in this lateral incisor. Mini was placed again with the guidance of R2 gate, and any reach of 3.5 in this central incisor. We are trying to use the smallest type of implant that we can. We don't like to use a big implants just to answer to a question that might happen again. So we really are trying to use 3.5 to 4 millimeters, not bigger implants than that. And this is the ISQ values that we have: 77, 64, 83, really high numbers of ISQ values. And then with this template, we place the customized zirconia abutment inside, prefabricated. These zirconia abutments, you can modify them also inside the mouth or from before. This is how these are prefabricated, everything from before. And then you can use different type of combinations on the provisionalization, either with fixed provisional or chairside provisional, really doesn't matter. Here you can see the perfect implant placement that was done at the before and after of the case. Now, it's a lot of discussion is happening lately regarding the complications. There have been several type of publications that we see. I don't agree in a lot of them because they include some of them. They are very tough with all of the PET techniques, because I think that they are comparing oranges with apples and not apples with apples. Some of them are periodontically compromised cases that they should not have happened with root membrane or socket seal or any partial extraction therapy technique, and it was a misjudge for myself. Also, we should have a discussion about what is complication and what is not complication. Because for me, for example, I do not consider the second stage internal exposure as a complication, but as a modification. Somebody else might consider it as a complication. So I don't know, but I don't know. Isaac, would you like to talk about this publication we have now from Zur, and go to the ones that you're saying, or you want to say
No,
yours now? And,
you can go ahead first, and I can show after. And I don't know where you want me to show the digital, or you want to skip the digital. Up to you.
I leave it to you. Now, this is the first type of complication we see as management of complication from the German group. So this is the picture that they provided to us, and this shows also the presence of the root and the damage that it has happened there. Clearly, it is not a severe type of complication. It is a very, very small complication that has happened there. You see the how much bone has been left there, and also this type of, let's say, a bridge of bone, outer side of the bone, and this is very easily to manage as a complication. Now, a big question, this is how the case started and how they did this operation. Again, you see the space, there's very small space between the root and the implant placement, but it's very clear, and I'm happy that how he said this also the other time, this Nezana's website, webinar, that in my opinion also the preparation of the root in this type of case was not properly done, because the root should have been lower prepared and in a different shape. There is no bevel here, and should have been a little bit different. Now the authors inside say this is the tissue, how they finished, and this is the management of the complication. As you see, it's not very difficult to do this and place some bone inside and do a connective tissue graft. This is the result that the German group gave to us, which I think it's very reasonable. Now, I don't know if I can accept or if I can agree to what they claimed as the why this happened. I think that there's a lot of discussion on this, and I don't know. I haven't seen this so much, but we can have a discussion on this. Personally, we have seen other type of complications like a foreign body insertion. This is Dr. Sherman's unique case. This comes from a fish. I think this was our mistake because we left an empty gap there, as you see here. And this, maybe it was a bad prosthetics, I don't know. But here you can see this, and look at the damage. Now, this is a real complication. Now, look at the damage that we had because of this foreign body that came inside. Now we managed to graft the case. And what I have to show you, this is a complication that we managed with Professor Silvestros here. This is a really beautiful case that we did together with Konstantin and him. And this we will try to get it out now because it's already 2 years, and it's 2 years of stabilized results. So this is the case how it started. This was a fistula there inside also. This is the implant placement that we had at that time, the preparation of the root, and very, very, very tough case. We grafted the area, also placed membrane and pins inside. The implant placement is very nice. Here you can see, I'm sure that Scott will agree in this. I think that we did have the initial stability. Maybe a longer implant could have been even better and maybe placed deeper in this case. But the case, and here you can see also that the length of the root, because this was like an experiment for us, it was not moving, but the length was very short. This is how this case was finished. The implant was placed by Konstantin, and the prosthetics was made by me, and lab technician was Michael Papastamos. I think that the result is acceptable, right, Scott and Isaac, especially with the fistula and how the case came to us. This is Absolutely. 1 year after. The color was not easy to achieve it, and the patient was not also helping. He didn't want to go also to do the lab, so we made this only from photography. I think it's an acceptable result, right, Isaac and Scott?
It is.
Yes.
It is fantastic.
Yeah, absolutely.
So
there's one question.
The patient,
there's
yes.
one question. In these kind of cases where you see the kind of fenestration or some pathology onto apex of the root, you make it a point to do a grafting into that area, or you just don't do anything?
You know, this is a beautiful question. I had a big discussion with one of the best endodontists we have here in Greece, Spiros Loratos. He's a professor at the UPenn, and he told me that nowadays, these kind of cases, we don't graft them anymore. I mean, apicectomies also, because the grafting material can be a source of bacteria.
Yeah.
So I don't know. I don't know if I can give you a clear answer to this. Maybe you should ask Isaac or Scott because they're more experienced than me in this.
My personal preference on those cases would be not to do the grafting in those areas and to try to do some type of space maintenance material instead. But a case like you're about to show now, where you have this amount of fenestration, would require something. You can't leave this without a graft.
Okay.
And I would
So
try. My
the
preference would
patient-
be in this case like this would be to harvest some autogenous bone to place over these types of threads. And I see you're about to use a laser here as well, which is what I would recommend.
This is the complication that happened to this case a year after we finished the case. So the patient came inside and he had this type of complication. This is a catastrophic type of lesion, as you see. So Professor Silvestros did treat this case absolutely with the great success. We used the laser to clean up the surface. We debride everything, and this is the result. I think it's a very good result of cleaning the lesion. As you see here, we have a huge type of lesion, but the implant was there. The implant was there. It was not moving. We had this integration in the parts that you see and in the palatal aspects also. And we used a membrane from Megagen, fixed type of titanium iGen membrane that we placed there, and we placed the tooth on top. So you see here the placement of the iGen membrane, the suturing of the iGen, and the crown that we had used before. We had the primary closure, of course, and this is the CBCT. You see, beautiful, beautiful documentation. You see how it came with before the implant placement, and also you see the iGen here, the outline of the, of course, the overbuilding of the bone, because we know that we will have absorbance, the overbuilding of the bone and the titanium outline of this membrane. And this is the result that we had 2 years after. So if you see the result that we have 2 years after, stable result with this huge type of lesion, I think that the result is acceptable. I don't know if it's the first time you see this, Isaac. What do you think about it?
Well, I think when you have cases like this and it's backfiring, I think that you're very lucky to be able to just keep the implant and maintain soft tissue in any form. I feel that once you've extracted the tooth, now you're coming back to what it would look like. Now that you've removed the root membrane, now you're coming back to what this would have looked like had you done a natural extraction where we lose the papilla. This is the problem that we've been dealing with for all these years. So yes, I think this is an acceptable result for what you would do whenever you extract a tooth. We lose that papilla quite often, unfortunately.
Yeah, there is a question now by somebody onto our viewers that what you will do about this black triangle little bit which is there, because it's a very wonderful result which you have got retaining, as Isaac said, that retaining the implant. So would you like to do some soft tissue procedures onto that to give it a better closing the black triangle?
So if the question was to me, I would suggest that I think the soft tissue would be very difficult to try to rebuild here. I would have done the soft tissue grafting at the time of the iGen membrane to cover it, so an attempt to try to do it. But now at this point, sometimes we can do more damage at this point than good. We have a great result, acceptable result.
Yeah.
So now we can manage with prosthetics. We could do some bonding. We can do some pink bonding if need be, as David Garber has shown, being able to bond those little pink triangles if necessary. So I would try not to do too much more work here because you've already maintained the acceptable result. And I think if you go too far, it may go the opposite direction with even more recession or more trouble if it doesn't work out correctly.
Yeah, thank you.
This patient, I think this is also patient centered and patient related, the decisions that we take in dentistry today. Because if you see, this is a very difficult patient that it's not easy to handle. If you see here also, this has plaque on the right side. This guy is not leaving us to clean his teeth sometimes, you know. So it's very difficult to put this guy and do an extra surgical procedure. And for me, the result that we have here from where we started and with the level of the complications we had, it's great. I'm very happy with this result for this type of patient. Now, there are other type of patients that they are very, they help the surgeon, and, it can be easier to handle them. I think that the result from where we started until now, it's way too good. Yeah. And if you saw before, I mean, Zur's paper that they published, and we're talking about Kurtzeler and Zur, that they are from the best surgeons in the world, okay? I mean, we all have been taught from them how to do plastic surgery, connective tissue, suturing, the one, the other. So if you saw their result before and what this result is, I don't think that we should make any comments to that. Now, Isaac, you should, would you like to show the case that, I mean, you're the digital expert. So would you like to say something about this and show the progress that we have right now?
With the digital?
Yeah.
You want me to show the digital cases?
Sure,
absolutely.
Yeah,
No,
we're at about 2 hours into this, so we got to move a little bit.
We'll wrap it up. Yeah.
I said we want to try to be done by Wednesday, but I actually was joking.
I'm all done here. I'm done. I'd like to thank you all for your attention. Now, I pass it to Isaac. I don't know if Scott needs to leave or not. Yes, you're right. We are 2 hours here. I think we covered all the material now.
Yes,
if Isaac is not in a hurry, he wants to show the guided thing.
Let's show some digital, and then we can maybe take some other question.
Yeah,
sure.
Yeah. So, would you like to stop the sharing so that Isaac can do some sharing? Is it going to be like that? Or you are going to show?
Yes. Yeah. Isaac is going to show from his computer, I believe, right?
Yep.
Yeah, sure. So you stop sharing, Miltiadis, and then no. You the green on the top. You say stop sharing.
I don't see it. Wait a second.
For
some reason I cannot do that.
Oh, just a minute. I'll do. I'm requesting something from you. A request to give me a
okay. I'm actually on now.
Yeah.
Yeah. Okay. So here we are. So we're talking about doing this marriage.
I don't see your screen, Isaac.
It's on Facebook. I'm looking at it on Facebook.
Okay.
It's live on Facebook. Yeah. You can show. You can see it.
I'm still showing Mitsias' screen.
Just a minute.
I think you're a little bit delayed.
Yeah, no. Just
here it is. Got it.
Yeah, it's on there. All right.
Yeah.
So let's talk about this digital handshake, so to speak. So we're going to marry the two worlds of being able to do this analog version that you just saw, that Mitsias showed quite well, and we're going to try to marry that into the digital world, into the digital realm, which requires some taking on our part and some technologies for guided placement. This slide, which you can see, is a picture of myself and Dr. Ganz. We've created these slides together that we believe that there are essential technologies that we need for being able to use guided implant surgery for placements and restorations. One of which is obviously we need to have a cone beam. Without a cone beam, it's going to be impossible for us to be able to diagnose and treatment plan these cases properly. We need to use radio frequency analysis, or ISQ, from Ostel to be able to tell whether or not we should be loading these implants that same day. Lastly, we need to take an impression or a intraoral scan so that we can do our merging of the STL and the DICOM data together in a software so that we can plan these cases appropriately. And we're going to need specialized software to be able to do that. So obviously the CBCT has become the standard of care. There are many papers about why we should be using the CBCT, and the CBCT is more than just a radiographic device for us at this point. We can do facial scanning, we can do impression scanning, we can do a lot with it. You'll notice in the top right-hand corner, you'll see this little article here about the lip lift technique. I always encourage using the lip lift technique, which Dr. Ganz published about 250 years ago, before there was even cone beam
Yes,
technology.
exactly.
He already
Yes.
published about the lip lift technique. But this enables us to be able to determine the soft tissue, the bone, and also to be able to see that triangular bone extremely clearly by utilizing that cotton roll lift lip technique, which I think is very, very underutilized in our profession, unfortunately. So moving along. So we have to marry this digital workflow, and this is going to seem like a fairly complicated slide, but it's really quite simple. We need to take a CBCT, we need to take a intraoral scan or an impression scan, and we need to be able to merge the two data sets together. Once we merge the two data sets together, we can then take the information and do proper treatment planning. When we have the proper treatment planning accomplished, we then can go all the way through towards our guided surgery, or if we want to do a template, just a small template or go free-handed, it really doesn't matter, but we need to be able to do that to do the proper guided treatment planning for our patients. So whether I'm doing a digital solution or I'm doing or performing this free-handed, I'm always incorporating all this data together, as is well published in the book from Dr. Ganz and Dr. Rinaldi, which you can find in Chinese, which I think is the easiest version to read. But if you want to use it in English, the book is called Computer Guided Applications, and it is available from Elsevier publishers. So I highly recommend this book. It's much more than you would think. It's not just about creating surgical guides. There's so much in this book: the sinus windows, reconstruction, wilcodontic style plate, bone plates, everything they've done fully guided. It's really it was an eye-opening book for me, so I highly recommend picking up this book at your Elsevier publisher. So obviously we're going to want to collect our data. One of the ways we can do this is just by taking a simple impression and then doing an intraoral scan in a desktop scanner. Another method would be to use the intraoral scanning. I like to use I have several different scanners. I like to use the ScanMate for my retraction. It's a non-reflective device that helps me go around the arches quite easily and pick up all the different nuances without having a reflective substance that's going to make my intraoral scanning more difficult. But there's many, many articles about why to use intraoral scanning in terms of how the clarity is, in terms of how the accuracy is. I find it to be more accurate than impression scanning. And I highly recommend, if you don't have an intraoral scanner, starting to look at one, because this is not just the future, it's the now. This is what we've been using, and I think it's where we should be at for 95% of our cases in implant dentistry. So merging these two data sets together, in this case, we're going to use an R2 gate from Megagen to be able to do our pre-planning. And we can plan it inside the R2 gate software. We can go into the R2 CAD design software and start to fabricate our temporary or even final abutments at the time of. And I prefer to use the final abutment whenever we can for a one abutment, one-time solution. So what's next is to be able to figure out which way we're going to go. Are we going to go free-handed? Are we going to go guided? And if we're going to go guided, you've seen the case that Mitsias showed that was guided. It's a very nice case, but it only showed guiding the implant. And we would like to be able to go guided with our preparation of the root membrane shield from the start, from the get-go. So by using this advanced planning concepts that this video is courtesy of Dr. Scott Ganz, and he's looking at planning not just the planning of the implant, but planning the direction of the drill. And you can see how the two go together. And then we call this the virtual root sectioning. We're going to try to figure out how much of the root that we are going to retain. And he is using here a guide tube to be able to create the shape of that root. And now we're planning to figure out whether it's going to be screw retained or cement retained. So you can see this guided root membrane concept can be accomplished through various different softwares. This is not an easy thing to do. It takes a lot of work. I sped that up quickly in the interest of time, but this literally can take, hours if not done to accomplish all these things. So it's a complex process. But through this, we've been able to come up with different surgical type guides. And one guide that I was very proud to create is something I like to call the Stackable Tooth Guide. This Stackable Tooth Guide uses Lego style pieces for us to insert into the locations so that we can then use different types of components. Whether we're going to be going for a sinus lift, we can put sinus lift drills in there. If we're going to be going for the partial extraction therapy root membrane technique, we can plan for the root membrane burrs, and we can also prepare for the implant osteotomy as well. So we can go with 4 different templates here. We have the template that you'll see in the upper left-hand side of your screen, which is going to show the actual Lego block piece. Then we have the surgical guide stack, which is going to be for the location of the actual implant. And then we have the apex stack. And the apex stack is going to take us all the way down to the apical portion of that shield, of that root, so that we can go straight to the apex. We don't have to go in any different direction. Lastly, at the top right, I don't know why the lettering is not coming up, but that is a C-shaped guide, which is going to be able to help us do our cutout. So we can plan from going interproximal to interproximal by doing that fully guided, which I'll show you in a moment. Another method for this, which I very much enjoy, which eliminates the upper right-hand corner stack, is to use the apex stack with, the surgical guided stack with Chuck Schwimmer's spot technique, which you can just keep drilling, and then remove the contents of later. Similar to the way the Greek group did it earlier, except by using osteodensification burrs to get better primary stability. Oh, there you go. That's the pet shaper stack. That was the last introduction in the upper right-hand corner. That gives us the ability to create that C-shaped type of a design, fully guided. So that's what the case looks like with all these 3 or 4 different components put together. And that's our new addition, which is the pet shaper stack. So here we are. We're going to take this case here where we're going to extract this anterior tooth, which has a minor endodontic lesion, and also has some ability of being able to retain the crown. It was de-cemented several times, and the crown to root ratio was not favorable. So here, first, we're going to place the guide, make sure that it seats perfectly. We're going to place our apex stack, and we're going to pick up our root membrane kit. We're going to measure, and this is the Tawil mirror handle, which has measurements on the mirror handle. And we're going to simply take that IS2 drill all the way down towards the apex. You can see that we've now got to the apex. We're going to take an x-ray to ensure that we are at that apical portion. So we can actually remove this without removing the guide. We can just remove that little Lego block and take the x-ray with the guide in the mouth and see that we've hit the apical portion there. We're then going to remove that apex stack because we're now finished with finding our apex, and we're going to put the pet shaper stack in, and we're simply going to ride along this C-shaped portion of you can see this metal C-shaped portion, following along to finish our cuts. We do not have to go very deep with this. We can use the smaller burr, but you can see that I've now completed my full, complete excavation of or preparation of that root shield or root membrane shield, so that we can now have a more interproximal to interproximal. The next step is to remove that, and we're going to extract using, this is the root membrane extraction kit, which you can find from my company, TBS Dental. There's the Icepick that I was talking about earlier today, and there's the Ganz forceps to remove the palatal portion of that root. And you can see that we've removed most of the root. There may be a little bit of root remaining. So what are we going to do to clear out the rest of that root in this fully guided type of approach? We're trying not to go free-handed. Keep that in mind. So what are we going to do now to bring this down to finish and preparing or clearing out the rest of that apical portion? Well, we're simply going to go back to the apex stack, and we're going to place the burr through reverse. Instead of putting it through the guide, I'm going to repeat this several times so you can see it over and over again. We're going to take the burr, go through the back end of the guide, goes through the back end of the guide, and then into the handpiece. So through the back end of the guide and through the end of into the handpiece. And this is going to give us the ability to follow the apex stack up and down to clear out the rest of the apex. So now we're doing internal shaping and internal clearing of the apex and finalizing our shaping. The last part, which should be done freehanded, is reducing it down to that bone level or just short of the bone level with the root membrane technique, which can be accomplished with the final end shaping burrs. You can see now that we have a nice, clear cut C-shaped type of a design, and now we can start preparing for our actual implant placement using our implant osteotomy guide. So we'll go through several burrs. We like to start with the short burrs and then go longer and longer so we don't change the trajectory at all. And then we're going to start using our osteodensification burrs to get better primary stability. So you can see with this design, we've changed the design a little bit. We have a little bit of movement on the guide itself. We've changed that over the last few months to be a little bit sturdier and have a pin place there. But we're using about 3 or 4 burrs before we're going to place the implant. And using that osteodensification gives us that better primary stability. It's an auto-compacting type of methodology. This is what we call the spot technique to be able, that Chuck Schumer developed, to be able to retain all that bone through that osteodensification. And then we're going to use the blue implant from Megagen, very much like the AnyRidge implant. And we're going to take it down using the standard R2 gate type of method where we could control both the horizontal and vertical placement of the implant by using both that black line for our vertical placement and the green line for our hex position. So we can now engage a final abutment. This is a prefabricated final abutment into its proper hex design. We call this the timing of the implant, where the implant is ending up. And this is paramount to being able to use a one abutment, one time concept that has a hex, octagon, trilobe, whatever connection you're using, but has that ability to meet that surface where you had planned it initially.
The rotational timing.
The rotational timing, thank you. So before we're going to place the implant, we're always going to use our, before we're going to place the final abutment or temporary abutment, we're going to take ISQ values to see where we stand and if we should be doing this by measuring the bone implant contact. Once that's done, we're going to take our, this is a cement retained crown with a final titanium abutment. I like to use the blue M gel in this type of a case, in any of these cases, to secure it and provide good oxygen to the area. And then in this case, because I have a little bit of a gap, I'm using some Nova bone to fill that area. Had I not had a gap, I probably would not graft in that situation. And now you can see I'm trying in my crown and I have a perfect fit on the crown. I did have to adjust it just a hair for the shaping of it, but it fit beautifully on the first time. And that's the key, not having to do a lot of work. Guided surgery, the difficulty should be in the planning part and getting that done right. But then the execution should be much simpler, because if you're executing correctly, then everything should follow suit and make your life easier. You don't have to fabricate a temporary in hand or on the side. Everything can be done in advance in a really nice manner. So you can see our immediate post-op and what that looks like. We'll be able to retain that root fragment. So we're going to have a good, hopefully good outcome. You can see I did not suture in this case because typically we get some creep that follows down to cover the root, which is very, very important in its healing. We're going to take a post-op x-ray to ensure that the abutment is seated correctly. And you can see the follow-up. And you can see the long-term follow-up. Look how this root eminence is preserved. And this is something that can't happen. You can see the adjacent implant just over to it has a flat or even a convex type of approach, concave type of approach. We want to be able to have a very, very nice emergence profile and be able to retain all that buccal tissue and keratinized tissue, which I think is unparalleled while using this partial extraction therapy root membrane technique. You can see our post-op result just a few weeks later. And here is our final CBCT. You can see that the bone fill has actually formed in between. This is at 6 months. The bone fill has formed in between that location. Another method, I'm moving quickly in the interest of saving time, is to be using dynamic navigation. Instead of just using the guide, the surgical static guide, we can go in a virtual type of a guided environment by using dynamic navigation. Dynamic navigation monitors the position of our handpiece, monitors the position of our patient, and we can use that with a computer, and this is basically Google Maps for implants. You point the direction of where you want to be, and now you just have to follow along that route. It's quite simple to do and has extremely high accuracy, as you can see from many, many studies that have been done by all the different navigational companies to show that it is just as similar in terms of static guide, with some improvements of not having to have the guide in the way. And it's also significantly more accurate than conventional free-handed implant preparation and drilling. So the calibration is quite simple on these. So the versatility of some of the units to be able to use different types of burrs is essential to be able to doing this in different procedures. So if I'm going to be using socket shielding, root membrane technique, partial extraction therapy, sinus lifting, if I'm going to be harvesting bone with a piezo instrument, I need to have a versatile instrument tool, such as this one from ClaroNav called Navident, which will give me the ability to use different burrs. So I cannot, or different hand pieces. I can use any handpiece or any piezo system on the market and calibrate that to this digital sensor that's in the navigational unit, which gives me the ability to perform various different types of surgeries. So I want to thank Joey Chen, as he published this article in 2019, and he's part of the PET research group in October in Joy. And you can see how he's planning his cases using a mini small diameter implant for the apex, and then planning the implant just parallel to that. So this is a dual part planning. You're planning one for the apex and one for the implant. So two different implants that you'll be planning within that software, which is very, very versatile and able to use in that Navident style. So you can see here is the implant and the apex of the tooth using a 1 millimeter diameter burr that he's going to use, or in this case, he's planning as a 1 millimeter diameter implant. So we did the same thing. We have a case here in the anterior region that's non-restorable, and we're going to use the dynamic navigation. We're going to use the IS-1 drill to be able to follow along, and we're going to be able to make our cuts. This is the coronal sectioning, and if you look to the right of the screen, this is just a slight delay of about a half of a second. So we're almost using this as a sonogram, where we're looking in, or fluoroscopy, where we're looking into the tooth to be able to see where our position of our drills are. We're then going to switch over to the IS-2 drill, which is that longer drill in that root membrane kit to find the apex. And again, if you're looking at the right side of the screen, you'll see that my drill is following along the pre-planned path that we can find the apex of the root. And now we're going from mesial to distal to be able to make our root sectioning cuts. Following that, we would then go ahead and extract that palatal portion. Very, very simply. Again, I'm using this root membrane kit that we developed from TBS with the Icepick tip, and then I'm picking up my just cotton pliers in this case because it came out quite easily. And now we're preparing the root reduction. And this should be done with the navigation. Unfortunately, you're not seeing on the right side of my screen here. It should be showing up, but for some reason it's not. Debridement of that site is crucial. So please debride these sites prior to going ahead and placing your implant. Now we're going to use osseodensification again. And now at this point, we've already switched over to these golden burrs that are available now from Densa, from Versa. And we're using the gold burr along, you can see on the left-hand side of the screen right now, following the osteotomy preparation, going all the way down towards the end of it. And you'll see on that green line, when that green line gets to the end, if it gets yellow or red, then we know that we're now starting to get at the very, very apex of the implant osteotomy prep. And you can see now I'm at yellow, and just in a moment I'll be at red, and we're at the apex. And we're done with our preparation there. Now we're going to go ahead and place the implant. So here is the Megagen implant, fully guided as well. And you can see how the implant insertion is also guided by the navigation. We've calibrated to the digital sensor, and we're driving that down to the apex using the Navident software. And you'll see that it's on the right-hand side. You see 1 millimeter, 2.2, 1.2. We're now at yellow, and we're at red. That's where we stop. Red is stop, and we placed the implant in the ideal position. And you can see we've left a little bit of a gap in this case, but we did not need to graft in this case. It was a small enough gap. Of course, the Ostel device was done. At this point, we decided just to use a healing abutment with some PRF material and some Blue M gel and come back because patient was under sedation at the time and he was getting a little antsy. So we decided to forego placing the temporary abutment, which I usually place on 90% of my cases that have good Ostel readings. But since we could not load it the same day, we still have the advantage of having Ostel device, ISQ device, to be able to measure it. So we can come back and just 6 short weeks later, monitor its progression and see if it's ready for restoration. So we can evaluate our quality of our navigation through the actual software. This is called EvaluNav, and we can superimpose the pre and post-op CBCTs in this case. And you can see that my entry was only off by 0.05 millimeters. My apex was off by less than a millimeter, and my angle was off by just 2.35, which is quite remarkable. We can get this beautiful type of an outcome without having to fabricate a surgical guide. So we come back just, this was about 5 weeks later, and you can see our ISQ values are very good, 73 and 71, 72. It's very similar to what we had when we had placed the implant. So that same day, we decided to take an intraoral scan, and just a week later, we were able to deliver our final crown. So we did a cut titanium anodized screw retained crown and abutment. And we can see this. You can see the long-term follow-up on this case. We can evaluate the CBCT and see the bone fill. We can see the good healing that happens typically with this root membrane technique. So that's it for the digital portion. I think, Mitsias, you did very well at explaining the complications, and I think it's been quite a long day. It's already 12:30 Eastern time here. So I think you did a great job with that. So I'd rather entertain questions than go through any more types of complications.
Let me say that I'm just overwhelmed. It was amazing presentation, and thank you so much for being with us. I mean, like a great educational presentation, which I can say, and I don't think everybody has this presentation has cleared the doubts in the mind of most of the people here. And having all three of you together, I'm getting so many compliments from all around the world. Marco Vega saying that this is a true education. And then Dr. Howie Gluckman being there saying, hi guys, for a big shout out. And there are so many of them. I'm really amazed by the presentation. And one question which one of my friend Dr. Dinesh Rai has asked, that when you have a situation where there is a very deep bite, and then if you are thinking of doing the root membrane technique into the anterior aesthetic zone, what is the precaution which you have one has to think?
Well, let me take that for a minute because
Yeah.
that really is a prosthetic question and not necessarily a surgical question. I think that regardless of whether you're doing a root membrane technique or standard technique or implants, you have to evaluate the bite and understand the forces that will be placed upon that implant. So I don't think that this is a specific question that would relate only to a root membrane. This is a question that would relate to any implant that we're going to place. So making sure that we have control of the forces that would be placed upon that restoration, and of course, evaluating the mobility of any adjacent teeth, etc. All of that is part of the diagnostic steps that we would take before going into this type of procedure.
Okay.
If I can add to that as well, I think I would not attempt to immediately load any of those cases because again, now we're not talking about having a tremendous amount of bone around the implant, right? This is not a healed site. So in any deep bite cases, and certainly in these types of cases, we're doing a lot of miracles in one sitting here. We're extracting a tooth, or we're extracting part of a tooth, which is even harder. Now we're trying to create a good solid osteotomy with primary stability, block out infection, block out soft tissue. Now to go ahead and try to combat a very, very difficult bite would be more problematic. So it depends on how many miracles you can do in one shot. I've seen some really beautiful cases from Odata and Ali from in India that have been absolutely outstanding. And they, if you follow on them on their posts of what they've been doing with these techniques, I think it's very, very valuable. They don't put themselves in harm's way either. They're looking to do amazing, miraculous work, but in a controlled manner. And that should be standard across in any type of an implant case.
There is a question that do you think that this Navy guide is going to replace the guided surgery? The guide? No.
I think there's two different things. So there's guided surgery with static guides, which is a wonderful method, and being able to develop its techniques. Secondly, the navigation is definitely more expensive initially, and I think that's going to stop a lot of people from being able to do it without that. But if you're talking about 20 years from now, maybe. But in the immediately near future, there are tremendous amounts of advantages to going towards navigation, but it's still in its infancy. If we're along the curve, and this is the same with guided surgery. If we're on the curve, we're just beginning to see climb the ladder, getting towards the apex of what we can do with this. And I think that there's a lot left to be developed over time. I think static guides have come a tremendously long way. And I think there's going to be a lot of value to being able to use them long-term and being able to print these guides in your office instead of having to use third parties. Free software that's available has certainly made it probably the most economical way to perform guided surgery, even comparing to Navigant, because it can only cost you, a few dollars. It's free software, a few dollars, less than $10 US, to be able to print a guide and plan a case, or maybe, I'm sorry, less than $20 US, to print a guide and plan a case. I think that's a very hard thing to pass up on from a case-to-case basis.
There's
I think it's
another
also,
you can add to that, please.
I think it's also important to note that regardless, I mean, first of all, navigation, dynamic navigation has been around for more than 20 years, and it's come and gone because the technology was really not there. Now the technology is much better, but just so that this is not lost in the equation, it doesn't matter whether you're doing dynamic navigation or you're using static guides. The planning has to be the same. And we're creating a static guide or we're creating a virtual guide, a virtual template. The planning has to be the same. And unfortunately, a lot of clinicians like to jump over many of the steps, or they think that dynamic navigation you don't need all of the steps to get to the same end result. And just to make sure that it's clear, you need all the same steps.
Thank you. There's one more thing people are asking about, and we had a webinar with Snejana Paul and Hovi. In that also, the same question came up, that do you recommend certain kind of implant into this root membrane technique? Because as I have experienced, Megagen, if somebody asked me which implant system which you have really one of the best in the world, any region, this I really love it like anything. I will recommend without any bias. So do you think that because of the typical design, which it has a slender neck, the implant system, it has any advantage into this technique?
Yes,
I
you want
think
to answer that,
that these techniques work with any type of implant. Okay.
Yeah.
You should know what you're doing. You should know how to provide the proper space in order to have a clear path. And on the other hand, I think it's a combination of the correct use of the correct type of implant. Whatever works in Isaac's hand doesn't matter, it works in my hands. So because the technique is sensitive and the space is, it's not the same, like you have the whole socket there, So you really need to know how to use which implant at the proper time. This means that, and I agree with you that, for example, the AnyRidge is like a Ferrari. It's an implant that can make your life. It can give you miracles. Okay, you can have an initial stability where other implants cannot provide you this. But you need to guide this, and you need to know how to use this properly. This knife thread design, this unique thread design. You need to know how to use it. Otherwise, this can give you a hard time. So it's really what works better and what you know how to use better. For me, this is very important. Okay.
Well, let me add one thing to that, Mitsias. First of all, I agree with you 100%. You have to know how to utilize the implant system that you are providing for your patients. But for this particular concept, and Isaac may chime in as well, I think that the socket shield root membrane PET concept is much more adapted to a platform switch designed implant. So whether it's an AnyRidge or others that have a platform switch, I think the ability to be able to bury that implant below the crest of the ridge and then allow for the emergence of your prosthetic components is just more advantageous with a platform switch design than a standard design implant that may create a wider prosthetic platform at the crest.
Again, two things if I can add to that. I think the two things that we didn't say completely was we need to accomplish that primary stability. That's going to be very, very important because we don't want a lot of moving parts going on in this type of a technique. So you need to use an implant that's going to get really solid primary stability, good torque, good ISQ. Secondly, we're going to need to be able to have a cutback design at the coronal portion of the implant. There are lots of implants that have that cutback design. AnyRidge is one of those implants that can do that. So if to maintain that prosthetic space with ease, instead of having to battle it, as Mitsias was mentioning a moment ago, you can use any implant, but you have to learn how to use that implant. It certainly has less of a learning curve if you don't have to deal with it at all because of the fact that the implant is providing some prosthetic space for you to begin with. And that goes back to the concept of platform switching as well.
Yeah, thank you. I think to conclude the session, I believe the biggest message which is there by this webinar, that if you want to prevent peri-implantitis in your cases, and if you adapt to this technique, the chances are going down. I mean, like that's the biggest advantage which I believe, because as you have shown into your cases that the volume, the soft tissue and the hard tissue volume is maintained, and where there is an immediate placement or any other technique has been followed, you see the reduction in the volume. So this is what is the concluding message you want to give to the audience? And then thank you so much for being with us. So this is what with this message,
the audience should get some rest and go to sleep. I think that would be the number one message.
Miltiadis, please.
I would like to first of all to thank you again for this honorable webinar, and for me it's just follow the rules of what we have described in the literature. Read the literature. Everyone has placed a brick in the wall, and now the bricks are a lot. So all the answers are almost there. Follow the rules. Follow what we have, written in the publications, and as we said, is this learning curve. It's for everyone, okay? And we're here to answer all the questions. I don't know if Scott Ganz has a more mature, let's say, type of closing up this whole webinar because of his experience.
Definitely.
I would like to add one thing. I think.
Yeah, let Isaac.
And then you can wrap it up. I think that with any technique, the most important thing is reading, as Mitsias had said, learning about the technique, and then learning how to perform these techniques. It's dangerous to now say, well, I watched the webinar and let me go and practice on my patients. Education is primary. Take hands-on courses. There are many courses available throughout the world. All the different programs are now including this. It's so beautiful from being part of this. And Mitsias and Scott, you have to appreciate this as well, to see what we started with so many years ago. And I wasn't the first. I don't want to make it like I was close to the first, but I was one of the early adopters of this. But to watch it progress from being banned from several different institutions, not being allowed to come in, and now it's being adopted, and people want to learn more because the longevity of technique has shown that it can withstand the test of time. Thanks to Mitsias for these long-term cases. Without it, I don't think we would have validation. Thanks to the PET group for all their contributions to getting it into groups like the American Academy of Periodontics or the Quintessence meetings. And these meetings are very powerful, high-level meetings, and they are being talked about at these meetings, and it is one of the hottest topics. So as with any technique, it's a great hot topic. Now the next step is, if you like this technique and you're not currently using it, go out, take some hands-on courses, and learn more about how to do this. Mitsias has courses all the time in India, as well as you guys have seen through the roadshow. So more power towards education and broadening our minds on the upcoming horizons of implant dentistry.
Thank you. Sir, Dr. Scott Ganz, the last finishing touch.
I think Isaac and Mitsias have really summed up everything very, very nicely. Great minds tend to think alike. And as our concepts continue to evolve, we have to all keep an open mind, especially with some of the technologies that are both new and those that have been around for a long time that are becoming new today. Just as Isaac said, these concepts may have been banned. I remember when people didn't want to take CTs and then cone beam CTs on their patients the same way, because they thought that was not a good thing to do. And we know today that we can't practice without three-dimensional imaging. So we are continuing to evolve, and we have to keep an open mind, and platforms like this and education are what helps to be able to spread the word. And Sandeep and your organization, we thank you for providing a platform like this to educate more people.
Thank you so much, Sir Scott Ganz and Dr. Isaac Tawil and Miltiadis, especially for coming down here. And definitely one thing is there, me and my team is coming to you. One thing is there. And the last statement by Snejana Paul, that I agree with Isaac T. Tawil, occlusive healing abutment or provisional crown are important for the tissue between implant and shield. So she has written it down.
I learned that from Mitsias, so I have to thank him for that.
And thank you so much for a wonderful, amazing presentation. And I will ask all my viewers that if they want to go into this technique, root membrane technique, take a hands-on course, which is very important, whether you do it in India or you come down to this amazing people who are doing hands-on on the patients in Mexico. This is what I believe. And definitely, yes, me and my team is open for it. And the moment COVID-19 situation allows us, post-COVID, allows us this opportunity to travel, that will be the first thing in the mind. And this is the collateral benefit of COVID, which we are, you all are here on a.
I want to add one more thing. Yeah, since please. You mentioned the COVID, please check out my new invention that Dr. Ganz was very kind to help us with. It's something that can really help a lot of us. So please, you can check out ShieldVac. ShieldVac and check it out. It's we need to find prevention. Look for some form of prevention. If it's not ShieldVac, please, to all the clinicians out there, please stay safe. Find auxiliary things to help you that can be affordable. It could just be a face shield, a mask, whatever it may be, to be able to provide good health. We want to see all the clinicians at the future conferences to be healthy and safely and have good enjoyments and a lot of fun in dentistry.
Thank you so
Everyone
much.
be safe.
Yeah.
Thank you.
So
Thank you
much.
so much.
Thank you,
Namaste.
guys. Namaste.
Being
Eid
with us.
Mubarak.
Eid Mubarak. Yeah.
Eid Mubarak, sir.
Yeah. Yeah. Thank you.
Take care.
Bye
Bye-bye.
bye. Bye bye. Bye.
Bye bye, sir.